Let us wait for 1 more minute and then we will start. Are we live on YouTube, Mr. Deepen?
Yes, yes.
Thank you. Okay. Dr. Sarita, I request you to introduce the faculty and the case.
A very good afternoon, everyone. On behalf of IAP Pune, I welcome Dr. Sunil Junagade, sir.
Hello, everyone.
Yes, sir. Good afternoon, sir.
Good afternoon.
So we were fortunate enough to meet sir during one of our inspections held few months back, and we had a very great enlightening interaction with him. Sir has done his MBBS from GMC Nagpur, and then he's done his DCH also at the same place, followed by DNB in pediatrics from Nair. He had worked with Dr. Mukesh Agrawal sir as his mentor. And he had very joyfully said, when I asked him his fields of interest, he said, we come from a genre when we had to see everything. So he said, I'm interested in nearly each and every subspecialty of pediatrics, including cardiology, neurology, and mainly infections. So, sir, on behalf of IAP Pune, we welcome you for this case discussion, and thank you very much for agreeing to be esteemed faculty of this presentation today. The subspecialty faculty, we have a very good colleague of ours, Dr. Abhijit Botre, who's consultant pediatric neurology in KM Hospital, Pune. He's done his fellowship in pediatric neurology from Hinduja, Mumbai. After that, he has his fellowship in pediatric epilepsy from USA. And he's been a very enthusiastic teacher for the PG students. And the case presentation to be done today is from Bharati Vidyapeeth, Dr. Niyati Shah, who under the guidance of Dr. Priyanka Barjate is today presenting a case of a floppy infant. So Dr. Priyanka, ma'am, and Dr. Niyati, ma'am, all the best to you. Dr. Niyati, you're ready?
Yes, ma'am.
Yes, so you can start, I think. Yeah. Dr. Niyati, you can start.
Yes, ma'am. Ma'am, the informant is the mother who is a reliable source. Father is working as a daily wage earner, a laborer, and mother is a homemaker. So 5-month-old female child, Miss Nuren, third living issue of a third degree consanguineous marriage, who is a resident of Konwa, Pune, was brought with concerns of decreased movements of all 4 limbs, which was noticed since birth, cough and runny nose associated with fast breathing 2 days prior to admission. So Miss N was apparently all right until 2 days prior to admission, when she developed gradual onset progressive bouts of non-spasmodic cough and runny nose since 2 days. It was later associated with fast breathing, which the mother had noticed, for which she was brought to our hospital. Mother also says that baby had reduced movements of all 4 limbs as compared to her older healthy siblings, which was noticed since birth. Mother has noticed these reduced movements were present even when the baby was stimulated or tickled. And she feels that these reduced movements are similar to the one prior deceased sibling. Mother has concerns that she...
1 second, Dr. Niyati.
Yes,
have you shared screen? We
yes,
are not able to visualize the PPT. Have you done the screen sharing again?
Yes, ma'am.
Yeah, now we can see.
Yes, ma'am. So I'll start with a brief complaints that the child was brought for. She was apparently all right 2 days prior to admission when she developed gradual onset progressive bouts of non-spasmodic cough associated with runny nose since 2 days. This was later associated with fast breathing since 2 days prior to admission. Mother also says that baby has reduced movements of all four limbs as compared to her older healthy siblings, which was noticed since birth. Mother has noticed that these reduced movements were present even when the child was stimulated or tickled. Mother feels that these movements are very similar to one prior deceased siblings which she had. She feels that Nuren has limpness of all limbs, which she had noticed when she would carry out her routine activities like changing baby's clothes, dressing her, changing her diaper, or bathing her, and her legs would hang loosely. She also states that she would have to grip her tightly every time she was held by the axilla. Baby's head would also hang loosely when the mother would lift her, and she also says that she would not reach out for toys which were kept in front of her with both hands, neither would she lift her shoulders above the bed. She wouldn't kick using both her legs or fold her knees in bed. However, she could move her fingers, grip her mother's fingers, though not very tightly, and would also wiggle her toes. Mother says that she recognizes her, smiles, and even laughs at them and makes a normal eye contact. So with this history, it is evident that baby has a severe gross and some fine motor delay with a preserved cognition and has some amount of symmetrical hypotonia with weakness of all four limbs with the acute complaints of a lower respiratory tract infection. Mother has noticed that the baby also has an abnormal pattern of breathing in the form of increased abdominal movements even while at rest. She has also noticed that baby had some difficulty in feeding in the form of choking episodes associated with collection of feed and small amount of saliva collection in the mouth, which would occasionally drool out. Baby would often respond to mother's voice, would cry to cold touch, any painful stimulus, and she was also noticed to have a weaker cry as compared to her older siblings. With this history, there is no any
I would like to interrupt in here.
Yes, sir.
You just go about the presenting complaints and past summarization in a brief. I mean, this, I mean, probably, yeah, I mean, you've taken it really very well. You've taken it in like details, but
Yes, sir.
would this be the real history that the mother would come to? So what you're saying is, I mean, the pull to sit manure, holding my axilla and all
Yes,
these
sir.
things, those are the examination findings. But what a layman, because look, this is like the forum that we're discussing. I mean, many of the people would know how to elicit that history and all these things. So if you would like to, I mean, summarize these two complaints crisply and very easily in like 3-4 sentences, how would you put them into? What are the main things which you would definitely focus, and what things which you can kind of exclude and don't give too much of, I mean, I would say elaboration on those points.
Actually, sir, the mother has a history of one sibling death,
That's
so
perfectly
she
fine.
has
That's what I'm
no.
saying. Yeah. So we
Yes,
have
sir.
one sibling who's affected.
Yes,
But
sir.
when now we are coming at this complaint, so how you just summarize those things?
Yes, sir. So 5-month-old Nuren brought with concerns of paucity of all four limbs, paucity of movements of all four limbs, which has been noticed since birth by the mother, and
That
associated
will
with.
result into what? Which you again summarized. So those things are, I mean, resulting into, I mean, non-achievement of the gross motor milestones,
Milestones. Yes, sir.
with which she can't turn over to one side, she can't hold her head, she can't grasp the things when offered to by both the hands.
Yes,
And
sir.
what else? I mean, when she's cried or when any painful stimulus is there is hardly any movements around the proximal girdles, around the shoulders and the hips. Though
Yes, sir.
the toes and fingers are little spared. Along with that, what central axial muscles weakness, how you, I mean, say, you elaborated it. So what is those? So you say she had a weak cry, right?
Yes, sir. A
Then
weak
she had occasional difficulty in, I mean, feeding and
following.
this choking and regurgitation of the feeds.
Yes, sir.
And along with that, now she has presented with her respiratory complaints, which probably
Yes,
she
sir.
never had. And one thing I would like to be little more concerned about is what are the, I mean, kind of a severity of this respiratory infection. Because this looks like only just cough cold and some hurried breathing.
Yes,
So
sir.
along with that, do you have any kind of a sentinel, I mean, things which would tell me, okay, this patient is coming to you for the admission. So this is kind of thing which is like telling me, oh no, that this now the respiratory symptoms are pretty kind of a, I mean, serious one, and we need to take little care of it. So what
Yes, yes, sir.
there and there is itself, along with rapidly breathing?
So mother has said that she did have an abnormal pattern of breathing even when at rest. But
Yeah.
since the past 3 days, she has noticed that it has worsened. Like the intensity of
Then
breathing has
what's the
increased.
history of
And
respiratory infection or low respiratory infection? What things which will tell you is a severe respiratory tract infection?
so this has resulted in decreased feeding of the baby.
Very good.
And she,
And
yes, sir. And the child has been persistently irritable, because of which the mother had gotten her to the hospital.
and what else? When you get pneumonia, what else findings you get on exam, or maybe history you can ask apart from increased rate?
So
How you know
fever.
the work of breathing?
So there'll be
So any where any
retractions.
depression? Yeah, exactly. So were there any?
No, sir. Actually, mother has noticed
Yeah.
that she had that baseline
This
difficulty in
mother,
breathing, which has increased.
history giver is true. The mother is history giver. So I mean, we did not
Yes,
talk
sir.
about mother because of course 5 months baby may not give you history. So this is informant is mother, but my only thing is now she's coming with increased rate, but
Yes,
may
sir.
not be these depressions are kind of noticed. Supracostal, intercostal, and intercostal. Along with there was no history to suggest of cyanosis. Baby is really irritable because she was not being fed, and baby had fever or no fever. So we are thinking of this is like URI or I mean this thing or this infective pathology which is going on.
Yes.
So where I will just kind of a little summarize all these things and then come to you. You have presented excellently. I'm not saying any, I mean, like concern about this, but I mean, lots of PGs who are again watching this, I would say, I mean, because this is a case where we are taking the, I mean, I would say a tip of the iceberg when you have this particular prototype, and definitely in your PG presentations, when you have 30 minutes, especially DNB in 45 minutes, this will be very difficult to say all these things. So then how you just kind of summarize the things and come to some things, because definitely these all things will be kind of getting repeated in your examination as well.
Yes.
So you have any things to make, Sunil sir?
I just wanted to ask her, she went about actually describing in great details the findings of examination, which you already had mentioned. I would like her to just stick to her cardinal 3 symptoms for which the child has been admitted. One, the acute one, that is respiratory. During elaboration, she can actually give a fair idea about the intercostal muscles being actively used, substernal indrawing, or a kind of depression at the lower end of sternum, which a mother can very easily notice. That is one thing which can give her an idea. Then the most important thing is paucity of movements. And she should have been actually going about by telling the kind of milestones you achieve. So 3 months, 4 months, 5 months, and she has not talked about being rollover, inability to roll over as compared to the earlier. So she should go into a little slowly, thereby building her own story. And then that other sibling death, we would like to know at what age the sibling died, because it can give you a fair idea how rapidly this particular condition is going to progress or is already progressing. So in history, I think she should be sticking to the information given by mother and just guiding her along, not prompting her by asking direct questions.
Okay, sir.
Otherwise, she has done a very good job.
Yeah, you can go on negative history.
Yes, sir. Associated with this complaints, there is no any associated history of seizures or altered sensorium, any history of abnormal sleep pattern or sleep disturbances, no history of any abnormal movements, and she would respond to mother's voice and make eye contact with the mother.
Why did you ask for the sleep disturbances and abnormal sleep patterns?
The UMN affection can have an altered sleep pattern and sleep disturbances.
Okay.
But on one hand, you are already saying that she can recognize the mother, smiles at, so you are actually ruling out a cortical affection. So why do you want to even think about UMN at this level when your story is going against the UMN thing very nicely?
Yes.
And your headaches and altered sensorium have already come. So
Yeah.
which of the element thing, you can get sleep disturbances and abnormal sleep patterns.
Sir, I'm not very sure.
So usually when you have a bulbar weakness, is any myopathies or neuromuscular disorder, where you're here even in my, I mean, like, see, I'm probably thinking this is like low motor and anterior horn cell disease. I mean, what you have is like decreased bulbar muscle, I mean, activity.
And
So
OC.
there are lots of choking, drooling, and this thing. And when you have this kind of a bulbar dysfunction, when your dead space of the respiration is being kind of compromised by secretion, they tend to get hypoxic, and then they get, awake. They tend to clear these things. Typically, again, I'm just kind of diverting because being from super subspecialty, I'm in congenital myasthenias. So they come with choking and those kind of episodes, and those are kind of very sentinel and can be, apparent life-threatening event even. But again, as I said, when you're going on categorically in the CNS axis, this was again probably not wanted thing. You should have put really up here. Okay, next.
There is no history of any difficulty in tracking lights, objects, or any squint noted. No facial asymmetry, deviation of angle of mouth. No history of any bowel bladder complaints. No history of any irregular twitching movements as noticed by the mother. She recognizes mother's touch, cold touch, and no associated any non-healing ulcers, callosities, or tongue ulcers noticed. There is no excessive flushing, sweating, absence of tears, or unexplained fevers. No any drooping of eyelids, any episodic apneas, diurnal variations, or waxing waning of symptoms noticed. There is no history of any jaundice or associated hypoglycemia. No history of any abdominal distension, recurrent episodic worsening, any abnormal odors, vomiting, or any vomitings. No history suggestive of any cardiac involvement in the form of any suck-rest suck cycle. So, yes.
Elaborative, more negative history, what you would like to ask? So when you're coming a baby who's like floppy and have, gross motor milestone delay with some fine motor milestone delay, cognition looks okay, social adaptive, social, these things are looking okay. What things you are differentiating?
So first on history, we would like to come down to motor neuron disease. So any
First is your UMN or LMN?
UMN or LMN.
So yeah, on your history, what you are so strongly suspecting?
Yes, sir. LMN, sir.
LMN, yeah, good. So UMN, of course, you ask for the seizures, this, like your cranial nerve pulse. And again, the examination, of course, you are focusing more on LMN. But when you're going categorized against schematic on the history, definitely, you should have said no cranial involvement in form of this.
Yes.
So any particular upper motor neuron, which can come with hypotonia or this kind of presentation, where few things I would probably, like to ask if at all, this, because everything is going so good. And definitely, there are PGs who are there to attend. So even these guys need to know. So any UMN lesion that you can think of, which can come like this, you need not to tell me you can tell me the disease, or you can tell me the CNS axis where you can have this kind of presentation. You may be wrong. It's okay. This is the platform you can, or
So hypotonic CP may come with.
Very good. That's good. So where this hypotonic CP comes from? Which lesions in the CNS? Where I would say the lesion in CNS?
So,
You're on track.
Yes, sir.
How a chronic teres would behave initially?
So initially they will typically present with dystonic kind of CP.
Chronic teres initially will have hypotonia.
Hypotonia, right.
Very hypotonia. Then they get, because dystonia are the structures and networks they laid later. So usually they will be very hypotonic and they become this thing. So what pathologies we are looking at is basal ganglia pathology. Again, you said metabolic causes, for example, organic acids, again affecting the basal ganglia, mitochondrial disorder, leads and all these things affecting metabolic and etiology. They will have this presentation to form with. Any other neuroaxis which can give us to this presentation? You're looking at basal ganglia. We finished that. Then I'll give you one clue. There are irregular abnormal eye movements. Cerebellar diseases where you have, central hypotonia,
Yeah.
those should have been gone little in kind of a detail, and bulbar and pseudobulbar, which we have kind of included. Yeah.
Yes, sir.
Why cardiac involvement did you ask?
So many element diseases are associated with cardiac involvement, like dystrophies are associated with cardiomyopathies.
At 5 months. You
Not
talk about
at
your case, yeah. You're right, but just kind of that's what I would like to probably even, get into the PGs even. So what is pertaining to your case? So 5 months, which disease will come with hypotonia and cardiac issues? You
usually
said
it's
hypoglycemia. I'm giving you a clue.
glycogen pompase.
Very good, yeah. So Pompeii is something which we'll think of definitely as one of the differentials, strong differentials. Go ahead.
And the specific thing she has mentioned in cardiac, no suck, rest suck cycle.
Yeah.
It is actually typically reserved for left to right shunts. So rather than using a very specific term used for a specific entity, she should be just talking about a broad suggestive cardiac involvement, something like that.
Yeah. And one more again, out of curiosity, how this baby was fed till now, 5 months? Breastfed or outside?
So initially breastfed, then had went on to feed via Vati spoons.
So do you think this baby would get sucrose cycle or no? How much time this baby used to take to feed? I mean, if you give 50 ml of milk, how much time this baby would take? Did you ask the mother?
Yes, sir. You would fairly take a longer amount of time to swallow that feed.
Because not just cardiac cause, your neuromuscular causes, even when you have kind of a breathing, because now you spend tachypnea and all these things, they even will have sucrose cycle, which is non-cardiac cause.
Yes.
So, I mean, when you said is non-cardiac involvement, so sucrose cycles, I mean,
Right.
yeah. You can go ahead.
Yes, sir. Child has had no previous hospital admissions for lower respiratory tract infections. Coming to the family history, this is a
Yes, so you haven't spoken about the visuospatial. I mean, like you just said tracking and all these things. The auditory thing you haven't mentioned. So child was responding to name. Was she?
Yes, sir. I've mentioned that child would respond when the mother would call her.
Okay. Fine.
Family history wise, this is the 3-generation pedigree chart. She is born to a 3rd-degree consanguineous marriage. And the first born of this marriage is deceased. The details have discussed further, sir.
And these 6 and 3 years are alive and well.
Yes, sir, alive and well, sir. So the first pregnancy was a female child born full term by a normal vaginal delivery, said to have cried immediately after birth and a birth weight of 2.8 kg. No history of NICU stay or any significant postnatal history. This child also had a motor delay with a normal social and language milestones. This child was also noticed to have paucity of movements of all 4 limbs with poor suck and a weak cry, and would also have frequent choking episodes. At 7 months, this baby was admitted to the PICU with a lower respiratory tract infection, required oxygen support for 10 days. Where this child was noticed to have paucity of movements and where he was investigated and some genetic evaluation was done. And eventually this baby died at 7 months of age due to the pneumonia.
Anything in ANC history which will tell you these are the kind of,
Yes, a decreased fetal movements, associated polyhydramnios is indicative of...
And one more thing.
Have you asked in details the antenatal perinatal history separately?
Yes, sir. For this current child, I have mentioned in detail, sir, in the next slide.
Okay, fine.
Yes, sir. Any malpresentations or abnormal lie? Or
bridge presentation.
Yes, sir.
True.
The second pregnancy was a 6-year-old male child. He is currently developmentally normal. And because the first baby was said to have some genetic disease, so mother underwent a amniocentesis during this pregnancy, which was normal, which was told to her, which was normal. Third pregnancy is a 3-year-old female child who is also developmentally normal. And fourth pregnancy is the current child. So coming to the antenatal history.
Any particular thing you should be specifically telling in developmental normal apart from that? So 6 years and 3 years.
So they have a normal, like the first child passed away at 7 months of age because
No,
of.
second and third baby I'm talking
Uh,
about. Of course, third baby, second baby the amnio was done. Third baby the amnio may not be done.
yes,
But then
sir.
what else you should have asked? So developmental normal. So here we are not kind of so keen on the cognitive milestones, but what are the motor milestones?
Gross motor.
So was
So
it
gross.
appropriately? Yeah.
Yes,
So
sir,
there
they're
you should have
growing.
little emphasize about those. Yeah. Those no 6 year. What is she doing? Is she hopping on one leg, riding a bicycle? I mean, running well as per peers. And 3 year again. I mean, she started walking appropriately. She's kind of running and kind of going upstairs with the support. So that is something I would definitely ask, because definitely what we know, I mean, you may have different severity in a
Yes.
presentation. So when they are saying developmental normal, so I mean, that would give me the exact motor, I would say, milestones.
Yes, sir. So the current index case, mother is a 28-year-old female, married for 6 years, was a registered pregnancy, underwent 4 antenatal scans which were told to be normal, took iron folate supplements and 2 TT injections. There is no history of any decreased fetal movements, any polyhydramnios, abnormal eye or any malpresentation. No associated complaints of any fever with rash in first trimester, diabetes, hypertension, or thyroid disorder during pregnancy. She was born full-term LSCS and said to have cried immediately after birth with a birth weight of 3 kg. The postnatal history, she had no history of NICU stay, no history of any postnatal seizures, any encephalopathy, hypoglycemia, jaundice, any apneas, or fever in the postnatal period. She was shifted to mother's side in 2 hours and breastfed. Mother did notice that she has a weak suck as compared to her older healthy siblings.
What are the reasons of weak suck in early neonatal period?
Sir, because of this associated history, neuromuscular cause can have a weak.
Yeah. So so some baby, some mother comes to you that baby is not sucking her breast at day 5 of life, without, of course, the sepsis component is ruled out. What are the things that you think of?
So firstly, we will check if the latchment is correct, rule out those causes. Then any local.
So the anatomical things are over. I mean, the anatomical and probably I would say, maternal anxiety and all these things are taken care.
Yes, sir. If there is any.
I would say, I'll put it in other way. If looking at the baby at 2 years now, or maybe 6 months now, these two complaints like poor suck and failure to thrive will kind of ring me some bells. Okay, I'm looking at this condition.
Sir,
Definitely,
HI
SMA or congenital myasthenias and neuromuscular issues are, but apart from that,
children with HI can have a poor suck.
Yeah. Then
Any
how do Prader-Willi present?
so they can also have.
They come in initial neonatal or initial infantile period as poor suck, failure to thrive, and after 1 year they will have, because we always have this notion that we are always kind of obese, all this thing.
Yeah.
So initially they'll present like this, and then later on they will have this thing. Then second, mothers having myotonic dystrophy. So there even they come with a poor suck, and the babies will have this expression, and they will have this kind of a poor suck. Again, neuromuscular issues where you have like SMA, you have congenital myopathy, then you have congenital myasthenias. They will have poor suck as compared to the rest of things. And of course, central, as you said, definitely metabolic encephalopathy, hypoxic ischemic, hypoglycemic encephalopathy, where the baby is like the brain is in the recovery stage. Definitely they will pull out, suckless. And one more. This one condition is called as periodontic polymicrogyria. So where the feeding mechanism, because it is bilaterally presented. So one part is developed okay. Still baby will suck well. So sometimes you just wonder, why these babies are not sucking. Everything looks okay, but when you have a periodontic area, when you have this polymicrogyria, the function is getting affected, and this baby will be, will be very difficult to feed, and this baby will go on for tube feeds for longer period together. Next.
Yes, sir. So she is immunized till 1.5 months of age according to government schedule, and BCG scar is present. She was exclusively breastfed and
Seriously think history. So 4 babies. First baby genetically counseled. Second baby amnio was done. What about
yes.
third and fourth?
So
During this
third,
time-
because the second pregnancy, the amnio was normal, she did not undergo for the third one. And
Okay, it was parental kind of choice. And third
yes.
was?
So the fourth one also, the current child, they did not undergo any amniocentesis.
And this was in medical institute.
Yeah, no, sir, in a private hospital. She was
Private
born, yes, sir.
Okay.
And then referred to a medical institute.
Okay.
Yes, sir. She is exclusively breastfed, and then later on Vati spoon feeds at home, and then post admission she was kept on OGT feeds, sir. Developmentally, gross motor wise, she had no neck holding, no bidextrous reach. Social wise, she recognizes mother and had some amount of stranger anxiety, and she would coo, sir. So she had gross and fine motor delay with a preserved cognition. Growth
No
wise,
partial rollover.
sorry, sir.
No partial rollover.
No, sir, no partial rollover. Growth wise, weight was 6.6 kg at the 50th centile. Length was 65 centimeter, which was between the 50th and the 90th centile. Weight for height was between the 3rd to 50th centile, and head circumference was 41 centimeter, which is at the 50th centile. So coming to the general examination, child was examined in supine position, lying comfortably in the mother's lap. She was afebrile at the time of examination. Pulse rate was 120 per minute, regular in rhythm, with adequate volume, force, and tension. Peripheral pulses were well felt. Blood pressures were at 50th to 90th centile. Capillary refill time of less than 3 seconds, and a respiratory rate of 38 per minute. Sir. Coming to head-to-toe
respiratory details will come into systemic examination? Or?
Yes, sir. Systemic examination. Head-to-toe examination, she lied in a frog-like posture. She has a chubby face and had nasal prongs in situ. There were no obvious dysmorphic facies, coarse features, or myopathic facies noticed. No any obvious...
myopathy.
Sorry, sir?
What are the constituents of the myopathy?
So myopathic facies, they usually have an open mouth, a tented upper lip, reduced facial expressions, may have associated ptosis, poor lip seal.
Very good. And some temporal hollowing maybe.
Yes, sir. There was no any obvious wasting of facial muscles, no temporal hollowing noticed. Hair was normal. Eyes showed no cataract, ptosis, or squint. Shape
would you
of the
like
head.
to, Niyati, would you like to talk about the palate also, about whether
Yes,
it
sir, I
is
mentioned
normal
there is
hair?
no high arched palate, sir.
Okay.
No high arched palate. Shape of the head was normal with no plagiocephaly. AF was open 1 into 1 centimeter at level. There was no pallor, cyanosis, or
5 months,
icterus.
isn't it small?
Sorry, sir.
5 months, isn't it small, 1 by 1?
Yes, sir.
What was the hair circumference? I missed it.
41, sir.
centimeters.
41.
50%.
50 centimeters. Was no pallor, cyanosis, or icterus noticed. Skin had no excessive Mongolian spot, any non-healing ulcers, callosities, or any signs of vitamin deficiencies. Oral cavity, there was an OGT in situ, no high-arched palate, no large tongue, no inverted V-shaped upper lip, or no fish mouth appearance. So tongue fasciculations were present. She had a short neck with some amount of retrognathia. Limbs were chubby with increased skin folds. No fisting was noted, no edema.
How did you check for tongue fasciculation?
So the child was lying quietly and her mouth was slightly open, and then we could see the fibrillatory movements of the tongue.
Okay. So for everybody...
Do you have a photo or a video of this child?
I have a video, sir, but I don't think it will get uploaded because of the bandwidth, sir.
Okay. So again, a caution for everybody.
Do you have photo also, na?
Yes, ma'am. Photo is there, ma'am. I'll show the photo.
So ideally, you should have the fasciculation checked when baby is not crying. And of
No,
course,
not crying. Exactly.
A bell-shaped chest with protuberant abdomen was noticed. No any hip dislocation or joint contractures. No club feet. No skeletal abnormalities noticed. Spine and genital examination was normal. Parents' examination showed no any myopathic facies, no grip myotonia noticed in the mother, no drooping of eyelids seen, no diurnal variation, or no variation in the facial weakness noticed, no pes cavus noticed. Sir. So this is the baby, sir.
So can you explain? Can you describe the attitude again here?
So the child lies in a frog-like posture.
With that frog. What does you mean by
Pithed,
the
yes,
frog? Yeah.
pithed
What does that mean?
frog-like. So pithed is when we used to do it in physiology, where we used to pitch the CNS of the frog, and
Yeah,
when he would just
what you
lie.
do is stop the inhibitory inputs from the cortex.
Exactly.
Yes.
And then you have element, I mean, this thing. So you see, I mean, they're just hanging by the side, hips are extremely rotated. You see the feet, even they're kind of, I mean, floppy. And one more striking thing is see the neck. It's totally as if he's hanging. So that again tells me, okay, there is, I mean, hardly, I mean, this, And second thing is you can see this redundant skin. Why?
So, because she doesn't use her.
And?
Because of the underlying muscle.
Very good. So hypertonia. So because of hypertonia, the counter of the muscle is not maintained and the muscles are getting degenerated. So we are losing the counter of the muscles, and that's the reason we'll have those kind of, appearance there. And if at all it's a male, I mean, in a general examination, what would you see?
Sir, any associate undescended testes.
Very good.
Why these fasciculations are there?
It's a sign of denervation, sir.
Okay, you get denervation in polio also. Then in polio, why don't you get fasciculation? Sir, I'm not. Both are anterior horn cell diseases, right?
Yes, sir.
So why don't you get fasciculation? I don't know. It's hard to see polio now. But in a polio, you would not see for fasciculations, isn't it?
Yes, sir.
So why do you want to see fasciculations, or why do you see fasciculations here?
Sir, I'm not very sure.
Is SMA progressive or non-progressive?
Progressive, sir. Progressive, sir.
Okay.
Yeah, that's the answer, isn't it?
When you have progressive disorder, when you have active degeneration going on, you can see fasciculation. That is the reason you can get fasciculation in SMA, not really in polio. And which is the other place where you see the fasciculation apart from tongue?
So deltoids can show, quadriceps can also show, biceps can also show.
You have a little bigger boy or maybe a little bigger baby and he's having the grasp. So where you will see the fasciculation and what is it called?
So it's fine tremors are also seen called polymini myoclonus.
Very good, very good. So polymini myoclonus, those are fasciculation of the small fingers, and that's the reason you'll get those kind of movements when you pinch. But again, taken with a little pinch of salt, because many of the other movement disorder or even sometimes ITS-like condition may typically resemble the same. But this again one of the, I would say, counterpart of fasciculation in the small muscles of the hand.
Yes.
And what is the physiological causes of fasciculation?
Physiological.
Especially working out of the muscles and all these things after gym and all these things, like movement like moving of the muscles, which is fasciculation.
Okay, sir. The systemic, coming to systemic examination, central nervous system, so higher mental functions.
Respiratory symptoms, respiration, where you have explained.
Sir, in the systemic examination under RS system, I have explained in.
Where is so prominent finding where your diagnosis is being clinched. You should have got this in general examination itself. Because that is the, I would say, the thing to say.
Okay, sir.
And there I do not really ask too many things. Okay, fine. Yeah.
Coming to CNS examination, higher mental functions, she was conscious, alert, and looking around. Speech-wise, she coos. Coming to cranial nerve examination. First cranial nerve examination, she anticipates feeds. Second cranial nerve, gross vision, she would follow light track objects, would recognize mother. Fundus examination was normal. Pupillary reflexes were bilaterally equal and reactive, both direct and consensual. Third, fourth, sixth cranial nerves, full range of movement of the extraocular muscles was present. No ptosis or squint. Fifth cranial nerves, movements of the jaw were normal and she would appreciate cold touch. I mean, wince to cold touch. Corneal and conjunctival reflexes were normal. Seventh cranial nerve, no facial asymmetry or deviation of angle of mouth seen. She would alert to sound. 9, 10, 11 gag reflex was present, no deviation of uvula. And 12th cranial nerve, the size, bulk and movement of the tongue were normal and tongue fasciculations were present.
How good is the gag? Is it normal or just present or is weak? Any comments?
So it was present, sir. It was not very prominent. It was present.
Not. Okay.
Coming to motor system examination, posture, she had a pitted frog-like posture. On inspection, she did not have gross visible wasting or atrophy, but on palpation, the feel of the muscles was soft. And the measurements on both right and left upper and lower limbs were symmetrical.
Why you didn't get a visible wasting or atrophy?
So because she is so chubby, it was difficult to see any gross visible severe wasting.
Exactly. So this is like the things which applies to your mid-arm circumference.
Yes.
The mid-arm circumference remains static from 1 to 4 years because the fats is get replaced by muscle. That means you are not the muscular muscle. That's the reason the count is so visible. That's the reason you not have this for muscle.
The tone wise active tone pull to sit, there was a severe head lag present. On flip test, she did not offer any resistance during the flip. Horizontal suspension, she would lie in a ragdoll posture. She would completely wrap around the hand. Ventral suspension, she would slip from the grip and lower limbs did not flex at all. Passive tone, scarf sign was present.
Only head lag and what else? What are the components of pull to sit?
Sir, even in like while the child is held by the wrists and pulled against the gravity, and in a normal child the head would align with the trunk, but in her there was severe lag. She did not even attempt to.
Along with that, what happened?
What about the elbows?
Exactly. What about
so they offer a resistance against the pull that we offer, but she did not.
They are in extension position.
Yeah,
they
so
grip very firmly, and along with that fulcrum, they will move their trunk, and the head comes. Depending on the.
And there is no flexion of the elbows. Ventral suspension, she would slip from the grip, and lower limbs did not flex at all.
Is it ventral suspension or vertical suspension?
Vertical suspension. Scarf sign, her elbow would cross the midline. Oplital angle and adductor angle both were extremely obtuse, and heel would completely touch the ear. Coming to PAR, PAR in the neck was only 1/5. Shoulder, they both right. Only minimal, sir. Laterally, she would turn, not even in the full range of motion, sir.
Okay. You don't have video of the baby, right? Only photos. But the video you said difficult of.
Okay. Yes. So shoulder, both right and left side 2/5. Elbow and wrist again 2/5. Fingers and muscles of the hand was 3/5. Lower limbs, hips was only 1/5. Knees and ankles also 1/5, and toes were 3/5.
Niti, did you talk about the occiput? You said there is no flattening or there is no
Yes, sir.
plagiocephaly, right?
Yes, sir.
But now you're saying the power in the neck is barely 1. So it
Yes,
is
sir.
quite obvious that the child is not at all able to move the head around.
Yes, sir.
So do you expect a kind of local alopecia patch with the
Yes, sir.
flattening there in this child?
Yes, sir.
But you are
Local
not,
or,
yeah,
but it's
this
not.
baby does not have.
No, sir.
Okay. Did you mention anywhere about the spine?
Yes, sir. I
Apart-
mentioned the spine and genital examination is normal, sir.
Okay.
Yes, sir.
I would elaborate around, not around the joints. I would say flexors of the shoulders or those kind of group of muscles, not the joint, because we see the power in the muscle.
Because this
Not
can be seen in elder and-laws also. Be this kind of angle she has spoken about.
exactly.
Can,
That's what I
yeah,
was wanted to ask you. And then one of the other differentials when you'll get this calves and everything.
right.
Okay.
So reflexes.
But as baby was too small, so it was very difficult to talk about flexor and extensors individually, I guess.
And any which way we teach our students that in infancy, the neurological examination, especially the power, is basically only an inspectory thing
Yes,
rather
yes,
than
yes.
actually handling the thing. Right? So
Exactly.
assessment done by inspection only.
Sir, but even if we're suspecting a differential like connective tissue disorder, she would have associated hyperextensibility of joints or easy bruisability of skin with
Not
this
all
kind of.
LL exams you'll get those. I mean, there are types, few of them. And then,
Yeah.
of course, I mean, as we say, as theoretical possibility, we're just discussing. I mean, what are the other things apart from hypotonia would give rise to this
Right.
scarf syndrome? These are
Yeah.
the Marfan even sometimes can give rise to this sign.
Yes. Coming to reflexes, superficial reflexes, abdominal reflex was normal. Corneal conjunctival reflexes were normal. Scapular was normal and plantars were downgoing. So deep tendon reflexes were absent. So all reflexes.
What about jaw?
The jaw could not elicit it very properly, but
What do you expect?
so it should be absent, sir, in an element lesion.
I mean, later, sometimes even you do tend to have cerebral nuclei who are like kind of getting degenerated. Usually is present. Or may not be this. I mean, definitely this jaw is something we always look for. The present is the thing which is taken this.
Sensory systems are there was no any apparent temperature difference appreciated between the limbs.
So what did you do about this? What did you do?
Sir, if there is any autonomic involvement, then she would have a
Change the temperature difference. You didn't check the
yes,
temperature in this baby, right?
yes,
Whether
sir.
she's crying on hot or cold.
Yes, sir.
Why did I ask this?
Sir, again, autonomic nervous system
No.
involved.
If at all for a normal baby, if you get some baby with a spinal cord lesion, definitely we would like temperature and the touch and all this. I mean, modalities to be checked. In this baby, when I say hot and cold perseverance is, I mean, done or not done, ideally should have not been done. But if at all, I mean, somebody would like to do it. So what is your take on it? Would you like to do it or you don't want to do it?
No, sir, wouldn't like to do it, sir. Not hot and cold, sir.
Why I'm asking? It's okay. I know that you don't want to. Why?
Because there is no difference in the skin temperature.
No, how do you check temperature? Temperature, I mean, sense in the babies or like in kids.
So if it's a smaller child, then we can't. An older child, they will verbally give a response as in
No, examination I'm saying. So what do you do? How do you check it?
by touching, if she can appreciate the touch, a cold touch or a warm touch.
Very specifically. So you have to take 2 test tubes.
Okay, sir. Yes, sir. And one with a lukewarm water and one with
Not
cold.
lukewarm. It's cold water and pretty, I mean, I would say hot water.
Hot water.
And if at all you want to check the temperature in this baby, what you will end up doing? Because this poor baby doesn't have any power.
Exactly.
So he may not move at all.
Scald,
He'll end
burn.
up
burns
Yeah,
and scars.
exactly. Exactly. So, I mean, with this kind of hypotonia, no, I mean, high, very low power, I mean, it shouldn't be tested at all.
Yes. No nystagmus was seen, and spine examination was normal, sir. Other system affection, cardiac systems are both heart sounds were well heard and no murmur was present. Respiratory system wise, paradoxical breathing pattern was seen. Otherwise, chest expansion was bilaterally symmetrical, no visible retractions other than the subcostal retractions, and air entry was otherwise equal and clear. Abdomen was soft, non-tender.
What do you mean by paradoxical breathing?
Sir, paradoxical breathing is occurs when the intercostal muscles are affected and the diaphragm is paired. So they have a
Explain me what is the
up-down kind of
what is the
movement.
paradox in breathing? What do you see?
During inspiration, the chest wall will expand and the abdomen should also expand during inspiration. But in this children, because of intercostal muscle weakness, this does not happen.
And what happens?
It don't know how to explain, sir.
So usually chest movements and abdominal movements are not in sync. Abdominal movements are much more as compared to chest movements. So definitely. And how do you assess it? How do you? I mean, what is the? You just look at it. You look at it and you know it is a paradoxical breathing, is it?
So we do splinting of the chest muscles to see if the intercostal muscles are affected.
Any other method to do it?
In an older child, a single breath count to see if
Tell me the intercostal weakness. Categorically, what you do is you place 2 coins, one on the chest, one on the abdomen. With each breath, you see what is happening. It's kind of a seesawing. So the abdominal coin will come up and the chest coin will go down.
Yes.
This is called as paradox. The abdomen will kind of bulge because of the is stronger respiratory muscle, the intercostals are not. So that's the reason, yeah, chest will be, and again, the pliability of the ribs and the chest wall is very low, so you kind of sucked in. So that's the reason you get this paradoxical breathing.
Otherwise, abdomen was soft, non-tender. Lower was palpable 3 centimeters below the right costal margin. Soft, rounded borders and a span of 8 centimeters. No splenomegaly. And genitals were normal.
Did you comment about the voice and cry?
The cry was weak, sir.
Weak cry, huh?
Weak cry, sir. Not loud enough. The mother herself. Yes, sir.
Okay.
So to summarize my case, 5-month-old female child born of a 3rd-degree consanguineous marriage has a paucity of spontaneous movements of all 4 limbs with motor delay and a normal cognition with generalized symmetrical peripheral hypotonia and weakness, proximal more than distal muscle involvement with respiratory muscle involvement, tongue fasciculations, areflexia, and apparently normal sensory and cranial nerve examination with no bowel bladder involvement and no systemic organ affection, with a strong family history of a similar illness in the deceased child, most likely because of element affection and anterior horn cell involvement, likely to be type 1 SMA. Other differentials that could be entertained are congenital myopathy, congenital myotonic dystrophy, and a congenital muscular dystrophy.
Niyati, before we go ahead, I just wanted to ask you, in a child so small, how do you comment on normal bladder bowel?
Sir,
what exactly you ask and what is the inferences you draw?
So mother did not have any complaints of bowel disturbances in the form that she would pass adequate number of urine 3 to 4 times per day. She did not have any associated complaints of constipation or encopresis.
Why do you expect constipation encopresis in this child?
Sir, SMA child will does not usually have bowel bladder affection, but other differentials like myotonic dystrophy will does have involvement of the
Which is the commonest cause of bladder void involvement in similar kind of story?
spinal cord involvement can have.
Yeah, syringomelia,
Like-
right?
Syringomelia, yes, sir.
Exactly.
Right. So
And
intramedullary
this-
lesion or anything which is in the
Yes.
midline of the spinal
Yes.
cord will usually present with bladder valve
Yes.
involvement.
Yes, sir.
And how do you differentiate between within LMN that this could be anterior cell, a peripheral nerve, a myoneural junction, or a myopathy? Because your immediate second differential is a myopathy, whereas your first is SMA type 1.
So because of this hypotonia, areflexia, and characteristic feature of fasciculations,
So what I
which
want
is
to ask
seen.
you is why the second differential becomes myopathy and not a neuropathy? What are the features in your story against neuropathy or involvement of myoneural junction? Directly the muscle involvement. You have 4 stations, no?
Yes.
Anterior cell, nerve, NMJ, and the myopathy.
Yes, sir.
So in your story, you are jumping from a differential or a diagnosis of anterior cell directly to the muscle. What are the features against the involvement of either a peripheral nerve or a myoneural junction?
So peripheral nerve usually has a distal involvement. So distal
So
muscle weakness is the
which are the
first.
3-4 things which come to your mind when you are talking about LMN and the peripheral nerve? Disease wise. Which are the examples?
So most common examples are Charcot-Marie-Tooth disease or hereditary motor sensory neuropathies are one of the most common neuropathies that present in late infancy.
Okay, now what are the points against that in this story?
The distal muscle involvement is seen in
Okay, very good.
So that will go against
And the neuromuscular junction involvement, conditions like those?
so they can have diurnal variation like a waxing waning
Waxing
syndrome.
waning, right.
Extraocular muscles are spared in this case.
Okay.
Facial weakness is not there.
Okay. So if your second differential is the congenital myopathy, which are the features which strongly favor myopathy and which are the features which do not favor myopathy in your story?
The proximal muscle involvement is associated with congenital myopathy. All myopathies present with proximal muscle weakness.
Myopathy dystrophies.
Yes, sir.
It is more like a dystrophy, no?
Yeah.
Yes, sir.
So dystrophy are more of a proximal rather than myopathy.
Yes. Yes. And again, hyporeflexia and areflexia.
What do you get in myopathy?
The
Same.
hypo or yes, sir.
So how does it differentiate one from the other?
Sir, other than this on history, we can't. Maybe with further tests like an EMG or an NCV.
We are at the end of the examination, so that's what sir want to even emphasize. So we have to be clinically, pertaining to those things. So when he says SMA, definitely anterior onset SMA, or then post is your post SMA, and then of course, as you say, there's no myopathic phase, respiratory involvement, fasciculations are there. So more of a neuropathy, you should have been put little more. And to favor that, what things you should have been on your examination? 2 things. What you gain, Chakumari, on examination?
So the pes cavus is present because of denervation of intrinsic muscles.
So this should have been there retrospectively on examination. The neuropathy, and what is the other anterior cell disease apart from SMA? Again, little, I would say I'm going little in detail in neurology, but still I think at your level you should be little, I would say.
Motor neuron disease like ALS can have.
ALS in kids it won't present. So this is basically 2, SMA, which is classical SMA, and second is 5q minus SMA, which is SMA where the SMA genetics are not similar, but many other conditions which is kind of involved in that. So lots of new genes are coming. Let's if at all we have time, we can discuss that. But those things again come as you say, anterior cell, most likely SMA, but then anterior
not linked to SMA.
The anterior horn disease involvement as well. Then you have neuropathies, which is again HMSN and your Charcot-Marie and this PMP22. Then congenital myopathy, and then amongst this, these 3 which will have, and again as you said rightly, your respiratory pattern fasciculation will take you a little more to this loss of pattern. And again, I mean, I was like wanted to say in myopathies, you have again patterns. I mean, you have kind of groups of muscles which are involved. So that will again will give you a little more clue. So not muscles are easily equally get involved. For example, DMD, you know the extension of hips, shoulders are getting more involved. Congenital myopathy, again, nemaline is more of a face. Few of them will come with respiratory failure. Few of them come with only, I mean, a lower distal muscle weakness. And of course, there are pluses and minuses in all. But as a PG level, of course, and myopathy will come with myopathic face and the rest of the other manifestations. Why this is not central hypotonia?
So firstly, because she reflexes, I mean, first reflexes are usually they have.
Which of these disorder will have central hypotonia?
I mean, sir, I didn't get the question.
That's the reason I'm saying. I mean, you have this kind of picture where you have CNS and PNS both. So which of this condition will have both involved?
So mitochondrial cytopathies can have both central and peripheral. HI can also, perinatal asphyxia can have both.
Initial stage will have. But again, HI, once the HI acute insult is over, your reflexes
Yes.
will be brisk.
Yeah, exactly.
Here you have a reflex.
Yes, sir.
Then?
Other than that, lipid and lysosomal storage disorders can also have affection of both. Familial dysautonomia can also have both central and peripheral.
No, among these, the condition you enumerated in the slide. What is muscle and brain disease?
Sir, congenital muscular dystrophies can have both.
Very good. So they have white matter hyperintensity. Because of
Yes,
that, they
sir.
have
Yes,
hypotonia. They have
cerebral malformations.
Exactly. Yeah. And how? What are the features which will tell you this is central hypotonia?
Central hypotonia, they have usually they have global developmental delay, microcephaly, deep tendon reflexes will be brisk, ankle clonus will be may or may not be present. They are usually associated with syndromic associations like Prader-Willi, Zellweger, Down syndrome. So they have associated dysmorphisms.
So basically, just remember this thing in
that
your
neurometabolic
mind,
disorders will also have a central.
Yeah. So when you have weakness along with hypotonia, weakness is not able to perform the thing. It's much more an element. And when you have weakness with power more than 3/5, it's usually central. Right?
Yeah.
That way.
So basically, very layman's language, floppy who is reasonably strong is a central hypotonia, and a reasonable, significantly weak is a element.
Yes, sir.
Element, true. So strong floppy and weak floppy and floppy plus. Those are three things which you should roll your attention into. And floppy plus are your all these Pompe's and metabolic syndromes and hypoglycemia and geratosemias and all these things which comes in. I mean, plus syndromes.
Other systems involved.
Yeah. Yes, we can go ahead. Just wanted to ask little. I mean, so her birth weight was 3.5. You said, right?
3 kg, sir. 3
kg. And she was 6.5, right?
Yes, sir. Yes, sir.
Centile chart, she has adequate. I mean,
yes, sir.
Yeah,
yes.
50th centile, you said, yeah. Because majority of them would have failure to thrive.
That was one thing I was wondering. She said that feeding difficulties are significant. She could not suck right from the beginning because that was the starting point of the story, and then still she is thriving reasonably well.
Yeah.
That is really, yeah. Okay.
Anything regarding something called as congenital benign hypotonia? This is out of interest. I would like Dr. Bhotri also to talk a little bit about that, because quite a few times in practice also, we tend to have everything normal apart from hypotonia, where we want to just tell the parent reassuringly that wait, things will turn out.
Yeah. So as she rightly said, I mean, there is an earlier term which was benign hypotonia of infancy, which is, I mean, or benign non-progressive hypotonia of infancy, which is no more used. I mean, it's kind of absolute. Definitely, when you have other features like delay, microcephaly, syndromic association, and this plus syndrome, definitely you can, I mean, need to investigate more and more, because now, I mean, of course, I mean, there are treatment available for the disorder. When you have, and now when you, as I say, sorry, even said, I mean, strong, I mean, floppy imprint. So you can say this benign hypotonia of significant, I mean, I would say outcome. That's what is kind of a terminology change. But again, as you say, this terminology can be changed. I mean, so earlier it was mental retardation and mental, subnormality, now it has come to intellectual disability. So these are kind of interchangeable things. But definitely don't, I mean, unless you have this few red herring like microcephaly, syndrome association, global delay, few birth history, definitely don't call this as benign hypotonia of infants.
Now, these terms are changing. I would just like to honestly tell one thing. For us at our time, any floppy infant, the prototype would be something called, we used to remember the Wernicke-Hoffmann syndrome, right?
Yeah, exactly.
Which, yeah. So for us, something like that. Now you have multiple SMA levels. So that is how the terms are changing every few years.
So Nitya, you said SMA, right?
Yes, sir.
Yeah, she said first.
Which type of SMA?
So
Sir
type,
has now bring those.
so
discussion
type
into here.
1 SMA, because she presented in early infancy. So most likely type
Yeah. Would
1.
you just tell few things about the types of type of SMA and how do they present?
Yes, sir. So type 1A is the prenatal type or a congenital SMA, and usually the line.
I mean, you got into lots of discussion. I mean, detailing. Okay, finish it off. I mean, we can talk testing later.
And they usually have less than 6 months of lifespan. And then is the infantile type Wernicke-Hoffmann, and they also present within 6 months of life, and usually have a lifespan less than 2 years. Type 2 presents at 6 to 18 months, whereas type 3, that is Kugelberg-Wielander, presents at more than 18 months and usually have a normal lifespan.
Any rule of thumb that you know, I mean, to remember all these things, because we've been taught like that. Because it becomes really difficult to remember all these things.
No, sir. I
So you
don't.
have 4, 1, 2, 3, 4, fifth column. So type A, I mean, never achieve any milestone. I mean, 1B and 1C never sits. Then 2 is sits independently but never walks. 4 walks but never runs. And 5 is, I mean, the 4 is normal. So that's what it is. So just remember those broad classification, and then you can probably know, I mean, what is what type.
Yes.
And again, probably we'll come to discussion why this is happening. How do you investigate this baby now?
So given the strong family background of that sibling death, most likely suspected of SMA, we will directly go for.
I'm kind of eliminating this all family history and past history. Now this patient comes to as a fresh case. So how do you investigate this?
So we
Now
would
your first
like.
definition, like neuropathy or myopathy. So how do you investigate? I mean, look, we are at a resource poor setting when, of course, I mean, these tests are available, but you have to use them judiciously.
We can do one creatine kinase, which will, if a very extremely high levels, could is indicative of dystrophy. May be elevated in myopathies also, but they are significantly elevated in dystrophies.
Yeah, yeah.
Yes, sir. To further delineate between a myopathy and a neuropathy, we would like to do
Any other test you do in your serum or blood investigation? Of course, this cognitively so well.
Sir, as a screening,
this baby is even having microcephaly, protruded tongue, cognitively little down, pseudo hypertrophy of muscle.
Karyotyping for Downs.
What is the differential for DMD?
Sir,
what are the causes of pseudo hypertrophy of the muscle?
so hypothyroidism.
Exactly. So those are the easiest.
Thyroid function, yes, sir. Cocker Debray, yes, sir.
Exactly. Would you do vitamin D in him? So commonly done test everywhere.
So they don't have vitamin deficient. They're not vitamin deficient.
Very classical signs when they're looking at you and that kind of thing. So definitely, of course, one of the co-contributors, but definitely not as the first thing. Then you have rest of resources and like cost. Yeah. So CPK definitely will give you the shift between the myopathies or dystrophic myopathies or no dystrophic myopathies. Then what next?
Is it absolutely essential to document a normal potassium before you comment confidently upon the tone of child?
Yes, sir. One of the reversible causes. Yes.
Ideally, yes. Yeah.
Yes. Otherwise, to further delineate between a neuropathy or a myopathy, we would like to do an EMG or an NCV.
That will tell you.
If it's a myopathy, then there will be small amplitude action potentials which will be seen, whereas
So basically, you the myopathic potential, which I mean the technicalities. I mean, let's not go into that detail. But myopathic potential, whether it's a degenerative procedure,
yes, sir.
or in nerve conduction, you get which kind of a neuropathy. Are you dealing with axonal, demyelinating, mixed, or you're dealing with motorosensory? So depending on that, you have would know is a neuropathy or it's kind of a anterior onset. Again, I mean, mind you well, I mean, of course, these things are there. At times, you may not get denervating potential in SMA in early stages. You have to do glutea, you need to do a sampling muscle very carefully because sometimes they just not pick a denervating potentials. They'll just show, I mean, low amplitude and no recruitment, but the denervation potential may not be really picked up on EMG and NCV. Definitely, it rules out your I would say neuropathy, and again done at appropriate center with appropriate techniques and appropriate expertise.
Yeah, that is what I was going to stress. This actually, these are so sensitive tests, and the margin between right and wrong and normal and abnormal is so thin that I think somebody who has experience in this field should be doing only these things.
Very, very true. And one more thing I would add here is you can do a repetitive nerve stimulation, which can, I mean,
neuromuscular involved.
Yeah, one of the myopathies, congenital myopathy, but ideally single fiber, I mean, EMG is kind of a gold standard. Of course, Pune has 2 centers which does it. But that is something which will tell you it is a this neuromuscular junction or not. Then?
And sir, muscle or a nerve biopsy, if the...
I'm telling you, okay, CPK is normal. So EMG you did, NCV did, NCV was normal, EMG showed, I mean, some denervation potential in the glutea. The rest of the muscles showed a low recruitment.
So then further will be a genetic test evaluation.
What test will ask for? What specification that test?
So multiplex ligation probe amplification for exon deletion 7. So that is 7, which is a... Sorry, sir.
Very good, I said, yeah. For exon 7 for?
The exon 7 deletion, sir.
Yeah, to know what disorder? SMA.
SMA, sir.
Yeah. So what is your interpretation? Do you have any slide on that? Because that will be a little easier for an audience even to understand.
Mention about the genetics of SMA. So the critical, the gene contains it. The SMN gene is located on the chromosome 5q11, and the gene contains SMN1 and SMN2, which are located in 2 different portions of the gene. One is on the telomeric region and one is on the centromeric region. So the difference between SMN1 and SMN2 is that it creates an exon splicing suppressor on the exon 7, in the sense that SMN2 skips the exon 7, leading to formation of an altered mRNA, which results in production of a truncated version of the SMN protein, and this protein, it gets degraded very fast. So multiplex ligation probe amplification methodology is currently applied as a diagnostic test for deletion analysis of exon 7 of SMN gene in potential probands. MLP along with sequence analysis is used to detect individuals who are compound heterozygotes with a deletion of exon 7 in the SMN1 allele. Hello.
Hello.
Sir, am I audible?
Yeah, you are audible. You are finished, no?
Yeah, yes, sir. This is the brief about MLPA.
Okay. Did you ask her again when she said that there were no decreased fetal movements and no abnormal lie? Which abnormal lie you expect in, suppose your diagnosis now is confirmed, it is SMA1 type 1.
So breech positions can be seen because they're not able to change lie because of the poor
movements.
Yes, sir.
Right. And the same is responsible for decreased perception of fetal
Follow.
movements.
Yes,
Right.
sir.
So it was not there with this particular pregnancy for this lady, right?
Yes, sir.
And she did not have the similar complaints even in the first one, which died at the age of 7 months.
Yes, sir.
So, okay. So what can you say about that then? That you cannot or should not rely on this history, or there is a altered perception if the mother who is pregnant for the first time may not understand what exactly you are asking and end up giving you a answer which may not fit into the story? Or
Yes.
is it very strong history, which usually is a must when you are expecting a diagnosis of SMA type 1? Is there a very strong correlation between these 2 points?
No, sir, there is not a very strong relation.
So it is okay that if some student does not want to ask or forgets to ask, will it not make any difference at all?
No, it's not okay, sir, to omit this history altogether.
Because in other words, how are you saying that right at the time of birth also the cry is weak, the suck is weak? That means the child is born weak.
Yes,
So
sir.
do you not expect the antenatal period also to be a reflection of the same pathology?
Yes, sir.
And many times what happens in SMA1 is what we see is, I mean, till 3 months, they are not that bad.
Right.
They tend to move their shoulder, they tend to move their hips and all this. And then
Right.
they see, I mean, they're delayed though, but then they start kind of regressing on their milestones and getting lost and lost. Because again, as I said, this is kind of active denervation which is going on, and this kind
Right.
of a apoptosis are going in anterior horns, and that's the reason they go down. So from birth,
And is there any correlation between involvement of the respiratory muscle? Like this is the first episode with respiratory issues the child is coming with. So is there any way of saying that suppose some child or infant is brought at the age of 2.5 months, about the prognosis? Suppose this comes at 5 months, the earlier the first one, I think presented at the age of what? Respiratory, similar, 5-6 months.
Yes.
7 months or so, yeah.
So what is the optimum or what is the time at which exactly the weakness starts affecting the intercostals? Is there a way of predicting it?
No, sir, I'm not.
Actually, what happens is like that's what so I was thinking. I mean, she'll come up to that SMN1 and SMN2 copies.
Right.
So the moment SMN2 will tell you the kind of the severity of the disorder. So
Okay.
SMN copies are there, and there as and as the copies are going up, increasing. I mean, this there is a grading of the particular illness, and you can predict where he'll get into. Of course, I mean SMN2, I mean 0, which is like very poor prognostic factor. And
Right.
2, the copies 1, 2, 3, what we say is more than 3, you have a little better kind of thing. 3 and 4 you have. But 2, again, your percentage which varies again as per that particular thing. But as what we say is as a norm, you can't really predict that. But again, it starts in little early infancy and can progress to, I mean, 6 to 8 months. And then they will have again bouts of those respiratory tract infection much more common again. And second thing is caretaker's attitude.
Right.
The way they're feeding, the way the infections are taken care. Because again, I was really surprised to see this baby is really well, I mean, kind of grown. So this is again little more, I mean, I would say, like difficult to, I would say, digest that this have 6.6, but of course, definitely with good feeding practices, energetic food feeds and all these things, there must have not been a failure to thrive or no.
So that is the next question for Niyati. Now that the lady is aware about the child's prognosis and diagnosis, as compared to the first child who died at the age of 7 months, what would you be telling her this time around as to the kind of care she should be giving for having a reasonably better prognosis this time? We cannot give her false hopes, but what are the instructions you will give her this time around?
Yes, sir. So, supportive management will include. So, first is coming to the respiratory system. We should ensure
Okay.
an adequate immunization. Mother should be taught about chest
What does
physiotherapy.
adequate mean when you say
Sir,
adequate immunization?
child should be immunized against pneumococcal influenza.
Okay.
Should be given. Then she should be taught about chest physiotherapy and postural drainage, and about clearing the child's secretions, because she might be able to not effectively clear because of her weak cough.
Okay.
Then nutritional wise, she should modify the consistency of the feeds.
Is there a component of gastroesophageal reflux in these babies?
Yes, sir. Yes,
So
sir.
that was another surprising thing. The child thriving so well means reasonably no reflux. So what you are going to say about the thickening of fits is especially useful when you are having this significant reflux.
Yes, sir.
Okay, anything else you will tell her?
Then adequate hydration, regular small feeds, optimize her caloric intake, and
Anything
yeah,
for the muscles to
sir,
prevent? Okay.
physiotherapy and orthosis in the long term to prevent scoliosis, contractures.
Mhm. So does she remember the earlier child who died at the age of 7 months? She was reasonably healthy like this child only.
Yes, sir.
Okay, great. Nice presentation.
Thank you, sir.
So what was the SMA analysis in the previous child? Do you have, or this
Yes, sir.
child you
The
have?
first, no, this child was not evaluated, sir. The first baby had tested positive for SMN1
You
gene
don't know the
deletion.
detailed genetic analysis, right?
No, sir.
Okay. So what is the, as the sir said, I mean, the treatment, of course, I mean, the supportive treatment, vaccination, immunization, feeding, and all these things, of course, expert care. I mean, if at all, I mean, it was earlier in, I mean, developed countries, it was a T-stomy and the feeding stomy. I mean, and then
Yeah.
they would kind of, I mean, keep their nutrition and decrease the current aspirations. What is the further thing? What is the further, I mean, I would say, consequence that will get because of this weakness? First is the feeding, second is the breathing, then?
Sir, orthopedic complications like joint contractures, scoliosis.
Very good.
Eventually,
So
they
those,
go on to have a
yeah,
reduced
stage three,
muscle
stage
mass.
four, yeah, exactly. They will have, I mean, lung disorder because of the mediastinum is getting compromised and they can't really breathe well and they can't aspiration will happen. So any treatment options?
Yes, sir. So, splicing modification of the SMN2,
No,
that is
what are the
new.
earlier treatment options? What is the current treatment options?
So earlier, initially what had come into the picture was nusinersen, which is an antisense
Before that,
oligonucleotide.
there are 2 years, 3 years recent advances. Before that,
Uh, so smaller molecules which
any
were,
SMN2 copies that you know of? Any medication, oral medication, which will increase SMN2, I mean, copies?
so
Suspected, I would say, I mean,
gene replacement
no, I
therapy.
mean, the valproate and asthaline was known to increase the SMN2 copies, but definitely not really, I mean, tested in randomized control trial that they would give SMN2 copies and can cause more. There may be as one of the additive, you can get, I mean, temporary relief or some improvement in function, but for long term, it is not really, I mean, good. So those are the things which used to be give SMN. That's what I'm saying. SMN1 is, I mean, kind of for disease telling, and SMN2 is your this is severity or modification gene. So the SMN2 is having more and more copy. That means your disease is milder and milder. SMN1 you have a copy. That means you have a disease, and then you have to investigate. I mean, list of the things according to that. And what are the further treatment? What you have is recent treatments.
So nusinersen is the antisense oligonucleotide that promotes the
Very good.
inclusion of exon 7. Then,
Yeah.
but this has to be administered intrathecally.
Yeah. So this basically what they does is RNA splicing of mRNA splicing of this SMN. This thing is kind of prevented. So you have more and more SMN2 copies. So you have little better phenotype. And as you said, I mean the doses. I mean first induction is by 4 doses, 4 weekly each. Then monthly and then 6 monthly to continue. And again, we don't know what model we are looking at. So it's kind of a not so assuring that the patient will be absolutely okay after that. And there are of course, I mean side effects of this. What is the second line of treatment?
So smaller molecules like risdiplam has been used.
Very good.
But advantage
And
of this is that oral administration. And the
yeah,
third one is gene replacement with Zolgensma.
very good. So that what does that do? That's viral vector, which
Uh,
has the SMN gene and it goes and kind of replicates in the human body and kind of strengthen the, I mean, kind of stop, I mean, or decreases apoptotic process and kind of halt the process. But again, The longer longitudinal studies are yet to come. They have like few of them have side effects, few of them have. I mean again, the cost in India is kind of a really huge. Again, we have few centers which are undergoing these trials. I mean, for example, Dinath has one, and AIMS and KEM Bombay has one. So the results of them is yet to come. But in interim results have come, but they are not. I mean, as we say, I mean, this could be, I mean, completely as we say, for DMD, we can make them to BMD, we can't make them normal. So similar here, we can decrease the severity of the weakness. And depending on when you administer it, when you are already the anti-hormone cells are damaged and kind of apoptotic, then the things are very difficult to get into the regeneration and the new, gain of the power, or gain of the function will be very difficult. Yeah. Any question from any of the other panelists? Or sir, want to ask anything?
No, that's it. There were 2-3 stories on YouTube regarding this, crowdfunding for this particular thing, and the stories. Yeah.
I don't see any questions in the chat box.
And second thing, one thing, what you'll do with this family?
The carrier testing.
Yeah, carrier testing, definitely. I mean, you need to counsel them, because going through this kind of a, I mean, infant loss is not so much. I mean, I would say it's advocated. I mean, twice they've been lucky.
But another way of looking at it is they have 2 healthy children. Might as well stop here.
Yeah, exactly. And again, carrier testing in home.
The 2 normal siblings.
Yeah, normal sibling and their, I mean, brother and sister, the father, mother's brother and sister, because they were potential carriers,
Right.
and they can get this in their family.
She said third degree, not third degree.
Yes,
She said.
sir,
So
third.
yeah, even their sibling should be tested.
So you should prevent anything to happen in that. So as this, we always ask, I mean, we have time, right? 2-3 minutes.
Yeah.
So, I mean, you did good, Nitya. I mean, if at all, I mean, this question has always been asked in DNB examination. How do you counsel a family? And there is the of all your new, I mean, because of course, I mean, you're getting into the shoes of clinician. Definitely, let's see, I mean, how it goes.
Regarding this current child, first of all, they should be.
No, you tell. I am the father. You just explain it. This is how, I mean, it goes in DNB. So I am the child of the patient. I'm the father of the patient. You counsel me in whichever language you're comfortable in.
So I will like to counsel the father that they are aware that the first child had a similar illness. So I would like to explain to them that this child also suffers from the same illness, and he needs to be. I mean, of course, we should push for a definitive diagnosis with MLPA. Having said that, they should be explained about the prognosis about his condition, and how explain the mother of.
I don't know. I just tell me. I am the father. That's what I'm saying. So give me 5 lines about the prognostication and current condition of the baby.
So currently the baby has pneumonia, which is requiring oxygen support, and the child has been kept on tube feeding. Other thing is that this child also has the same condition as the first child that was deceased. So I would like to probe you to undergo the same genetic testing as this child. Sorry, sir.
Which condition this baby is having?
Spinal muscular atrophy.
Yeah, so the disease which will kind of weaken the muscles and the nerves where the denervation of the muscle starts. So in turn, it will be kind of a progressive condition which will weaken much more muscles. So now the limbs are weak. Soon the breathing and the feeding will be difficult, and then this will be progressive disorder. Yeah.
Yes.
And there's likelihood chance that even this baby, so we have to confirm with this. This may happen in further pregnancies, and we have to rehabilitate this baby by, respiratory and feeding care and giving recurrent, this thing. There are therapies possible, but with one child now, we have to discuss these therapies, and there is very high likelihood chance that this happens in your, again, next pregnancy and your kind of parents, siblings, kids. So this completes your entire counseling.
Niyati,
Yes, sir.
this father is a man with resources. He wants you to do everything possible for the child. Are you going to ventilate and do a feeding gastrostomy for him?
Not ventilate the child, sir. I will do everything in my part to prevent invasive ventilation.
Why won't you ventilate?
Because, sir, once if, yes, sir.
Once he comes with bad pneumonia, so this kid doesn't likely has no patch. But if he comes with patch and he comes in kind of a gasping respiration with lots of cyanosis, so you'll say, I'm not ventilating.
No, sir. If it's a last resort, then yes, we will definitely intubate. But if it's preventable with non-invasive ventilation, then yes, I would definitely prefer a non-invasive ventilation, because once the child becomes ventilator dependent, it will be difficult to wean him off the vent. The vent will do all the work of the muscles that he is not doing actively, so it will be difficult to wean him off the ventilator.
Yeah. Any other type of SMA that you know apart from SMA?
Sorry, sir, I didn't get the question.
Any other SMAs that you know apart from SMA 1 and 2G?
There are other types of SMA which are not related to SMN1, which are variants of SMA.
Very good.
They're associated with
Okay,
Pontus.
I'll just elaborate a bit. Yeah. So there are 2-3 other variants which looks like SMA but not SMA. So one is X-linked SMA where you have X-linked predisposed lesion presents a similar way. There's one more which is called as SMA RD. So which is again perennially, which comes with respiratory distress, lung collapse, hypoplasia, lung, and lots of growth retardation. And there are other few genes which are associated with comes with arthrogryposis and intrauterine growth retardation. But unfortunately, they are all parentally so lethal, but so they may not go to the further level. And what is the Phasio-Londe variant of the SMA? It's basically bulbar. So it's riboflavin transporter deficiency when you have lots of bulbar involvement. And your rest of the axial muscle, appendicular muscle looks okay, and giving riboflavin therapy may potentially get the baby better. So the few SMA looking conditions are having really good favorable prognosis. So for example, I have few congenital myasthenia who comes with choking and all these things, and after giving few different kind of myasthenia, few of them may have treatment and they may do better on the treatment. That way. So till the time you're diagnosing the baby, definitely when the prognostication should be little, I would say, guarded. Rajesh sir, anything more?
No, I think we have discussed quite extensively, and I think it was very, very well presented by Dr. Niyati and very ably guided by Dr. Priyanka. And I think if there are no more questions, we can end this session. I would like to thank Dr. Sunil Janagade sir and Abhijit Botre sir for joining with us today, and very extensive discussion on SMA. And we hope that all the students who are attending this clinic have benefited from the expert faculty. And we hope to see you again.
I actually want to say this thanks to Abhijit. I also learned a few things because reading at this age and the tenacity it requires is not there with me. So learning from an expert is usually the best way. Thank you very much, Dr. Abhijit.
I think even I would thank, we all should thank Niyati. Because
yeah, exactly. Her presentation was very, very.
Many caveats in history and examination that you
she's very well read, actually.
So she
yes, so very well presented, Niyati.
Yeah.
Thank you, ma'am.
Yeah. That is, that take us to the discussion part a little more.
Correct.
And I then mentor Dr. Priyanka, and she even guided her very well.
Yeah.
Thank you, sir. Thank you.
Thank you, Dr. Janagade, sir. Thank you, Dr. Abhijit. All the best, Priyanka. And all the best, Dr. Niyati, also for your upcoming exams and everything.
Thank
right.
you.
Yeah.
Okay. Thanks.
Yeah.
Yeah.
Sure.
Okay.
Bye.
Yeah, shall we?
Thank you.